Hi guys.
Hey, how's it going, Rukia?
Oh, that's me, Kiani.
Oh, sorry. Hey, County, sorry.
Sorry. Rukia, I'm gonna make you host, okay?
Okay, perfect. Thank you.
Yeah.
Sorry, it's past my bedtime.
I know, right? This is considered like after hours.
Well, I'm in Texas right now, so it's much later than in Hawaii.
Oh, you're right.
Okay, let me get where is the screen? How's the semester going for both of you guys? Oh,
Not too bad. Coming to an end soon, so I'm glad for that.
yeah. Oh, this is your first semester as a grad student, right?
Yeah,
Oh, any different than undergrad?
a little bit more fast paced, but I definitely got used to it pretty quickly. I had to.
Yeah. It's not the courses that are hard, it's doing the courses and the research.
Right.
I'm not in school anymore, which I'm glad.
Yeah.
Yeah. Are you always in Texas or are you just there for
No, I've been there for the past few weeks for training. I get back, come back to Hawaii on Saturday. So,
Oh, nice. Okay.
Yep. Yep. Hey, Yosh, thanks for joining us. Well, I guess we'll get started. I don't know. I'm not sure who RP is, but thanks for joining. Rukia or Kiani, can you allow me to share screen? If not, can you pull up the presentation? Doesn't matter either way.
Okay, you should be good. Let me know
Okay.
if that works. If not, I can pull it up.
No, we're good.
Okay.
Okay, let's see who's there. Good afternoon, Jim, RP, and Yoshi. Thanks for joining. It's been a long time since we've had our monthly webinar. Apologize, last week was Veterans Day, so obviously need to honor our veterans. But we are back this week. So even though a lot of people may have moved on from COVID's still here, but the frame and the mindset by which we're looking at it should also be shifting. So Japan, or let me see, so Japan, no major changes since when their surge in, when they had the Olympics. Korea is going through a mini surge right now, but once again, if you look at the left column, it's relative. It's up to close to maybe like 2,600 daily cases. But once again, when we shift to looking at the United States, that's nothing compared to where we were for any of our waves. So once again, keeping things in perspective. RP, good question. If they haven't been posted for today, they will be posted after today's webinar. So definitely will be up. India, once again, no, continue to trend down. And so just to make that point, if you look at the surge that India went through, compared to what South Korea is going through, it was such a spike that the area under the curve, is still way more than what South Korea has gone through. Yeah. So the whole topic of natural herd immunity versus natural herd immunity versus non-mRNA vaccine. So can you elaborate more on non-mRNA vaccines such as the Johnson and Johnson or the AstraZeneca? I think looking, and I'll touch upon this, when we get to some of the deeper dives, the science highlights. But Yeah, so India vaccination rate, obviously they are lagging behind the first world countries. But once again, there's a lot of vaccine inequities, but a lot of their population, if you go back to the sorry, let me go back. If you go back to what they went through, a ton, just a sheer number of their citizens, were exposed to COVID, but also died of COVID as well. So, they paid a heavy price for having a strong, a big portion of the population that that were exposed and experienced natural herd immunity. Now, once again, uh, just because they have, a large chunk of the population got COVID and recovered, does not mean that they are not susceptible to getting new COVID infections. And it's while their immune response may be similar to someone who was just vaccinated, who was fully vaccinated without being exposed to COVID itself, that doesn't necessarily mean that that's a good thing, right? Because you're taking chances depending on your own individual health by contracting COVID and potentially progressing to the disease. To maybe going to the hospital, being on a ventilator versus getting a vaccine and still getting that same antibody immune response, but you're not at risk for going on a ventilator. So that's that. It's still too early to tell how long pure natural immunity lasts. And so there's a lot of unknowns, and especially because India was one of the first countries to really get hit hard by the Delta variant, as Delta is the dominant strain still globally today. I suspect they're not going to see a strong spike unless there's a drastically different variant that comes along, unless the Delta spreads to places in India that weren't yet affected by their major surge. Now, in terms of non-mRNA vaccines, efficacy is definitely not as strong. Novavax was just approved, but once again, I think the concept of vaccines writ large as the sole purpose of the sole key to keeping to stopping COVID is a fallacy. We cannot vaccinate ourselves, at least as a global community, out of the pandemic. It's we're seeing it time and time again. The virus mutates, and there's human behavior, and with most viral diseases, vaccines themselves are not the sole answer, especially given how much of the world has yet to be vaccinated. In terms of seasonal surge, with most experts thinking it's going to be endemic, we'll see surge, but once again, surge is a relative term, right? Is it a surge in cases, right? Surge in cases is not the same as a surge in hospitalizations or deaths. So, as we progress through experiencing and living through COVID, we have to reframe what it means to see a spike in COVID cases, especially with not continued development of better early treatments, right? I think it was Merck. I don't think it's been approved yet by EUA, but it's close to, a pill form of an antiviral, which will significantly reduce early symptoms. And plus, you have your IV antivirals as well. So there's a lot more tools in our toolkit, and especially given how I guess the silver lining with the Delta variant is, given how infectious it is, it really cut through a lot of the population. So if you were to look from an epi standpoint, what is the current population at risk in the United States, in Hawaii, across the world? Obviously different, but what is the true population at risk now that has not yet been exposed to COVID, either through natural infection or through vaccine? And I would, at least in Hawaii, I would say it's very small. So once again, a surge there needs to be a lot of context when we say the next surge, or the seasonal surge. Looking at us nationally, yeah, we're seeing an uptick. There are still pockets of our country that are less that have less vaccine uptake. But once again, that's par for the course, and it's a larger representative of a larger situation globally. So once again, there is no black and white for the situation, regardless if we're talking about Hawaii, the country, or the world. So yeah, no worries looking at India. I think, I don't think you'll find anybody willing to put down a lot of money to estimate, to guess where we're going to be next year. But I think you're going to see more and more scientists that are hedging towards not seeing a major spike unless you have that very rare crazy mutation where just you see such an escape in a variant that completely renders current vaccines useless, and that's always a possibility. Looking at the states, Arizona, California, nothing too crazy. Once again, you're going to have variations across states within states. There's not much we can do but to monitor and then apply that to our individual risk calculus as a state and individuals. Nevada slowly trending down. Texas, slight uptick up, but once again, it's too hard to tell right now if it's going to continue to trend up and why, if it is trending up, why it is. Looking at our state, cases per 100,000, obviously a pretty volatile for Kauai, but for the most part, for the Honolulu, Hawaii Island, and Maui, relatively stable, as is our percent positivity. I think right now we're getting to a point where in Hawaii, we are getting to another new normal in terms of 80 to 120 cases per day. Once again, that may be the new normal, and that's not necessarily a bad thing, because cases, without context, it's neither good nor bad. It depends how many of those cases translate to hospitalizations, and currently, our healthcare systems are not close to being overwhelmed. And then looking at the percent of our population that's currently fully vaccinated, 72.3%, boosters in certain populations are being administered. If you look at that purple, over 140,000 doses are being administered, have been administered. So, the booster or that third dose, especially for those immunocompromised individuals who truly need a third dose to get to that same level of protection, a 2-dose series would give, to a healthy, regular adult population. So moving on to our HiPAM forecast, pretty accurate in terms of where we are compared to the real data. Once again, I think it's, we always continue to keep it just out to 2 weeks, especially given, the situation where we are today with so much of our population being vaccinated, and what it means to be a positive case and the impact to the hospitalization and deaths. It is not quite, it is definitely not as simple as it was pre-vaccine, and also now early treatments that are widely available now. So 4 highlights I wanted to touch upon. I know we only get a chance once a month to really discuss, so wanted to touch on some varying issues across the Pacific region. So South Korea loosening COVID rules after massive vaccine uptake. Now we're seeing cases, hospitalization surging, as was evident by the previous slide. And you're going to see people saying, this is a case to not reopen, but South Korea did have a large part of the population immunized. However, their case fatality rate is still extremely low. And so what that tells is, looking at cases versus hospitalizations, and in context with specific countries. We can't directly compare South Korea to Hawaii to Germany to France. That there may be some similarities, but there's so many different potential differences between how each country deploy their vaccines, and also how Delta moved through their population pre and post vaccine efforts. Okay, sorry, just checking the chat. So obviously keeping an eye on South Korea because they are in the Pacific region, and then Europe is going through a bit of a COVID surge right now. According to the WHO, COVID infections across the European continent rose by 7% and deaths 10% over the past week. Nearly 2/3 of all infections were in Europe. But once again, most of the rise in cases and deaths are in parts of Europe where vaccine uptake is not as high. But admissions in hospital and deaths across Europe are still lower. So, looking at how quickly the vaccines were deployed in Europe versus United States versus Hawaii, you can't simply say Europe is going through a surge even though they're vaccinated, so that means vaccines don't work. There's much more nuance. You have to do a much deeper dive, especially given how big Europe is. Have I looked at UK data? In all honesty, I haven't had the chance to look at UK recently, but I can take a look. It's hard to stay on top of COVID across the world. Really focusing on Hawaii. Yeah, no, I can totally take a look for next time. It's just as a lot of the world has kind of started to shift beyond COVID. Not saying I have, but there are a lot more competing interests that HiPAM is dealing with our members. We have to teach and return to other parts of research, but we're still keeping an eye on COVID. So we'll look at the UK as well. And what this chart shows is vaccination percentages versus daily COVID deaths. And obviously, the black and the blue, the dark blue, so Bulgaria and Romania definitely lagging behind other European countries in the vaccination efforts, and it's transparent, and it translates to the daily deaths, and nothing new in terms of, we know vaccines, the 2-dose vaccines, Pfizer, Moderna, are highly effective against hospitalization and death and severe infection. That is without a doubt. Now, yes, 6 to 7 months after antibody levels will decrease. You have an increase in risk for infection, but once again, infection is different than hospitalization and death. So, there's a lot more nuance to that. Yeah, I'll definitely take a look. So in the, let me see which, this is, so in addition, so this is the Guardian. So Dr. Fauci was quoted that a third shot boost for an mRNA vaccine is likely. I think the word booster is not maybe accurate. Maybe it should just be instead of a 2-dose series to the 3-dose series, right? So because I think the term booster has been hijacked politically, and what needs to be acknowledged is probably, as the science evolved, as COVID has evolved, we're realizing that we have to deploy this in real time. But if we had more time to study it, we would probably realize that it's a 3-shot series or a 2-shot series. There are a lot of vaccines that we get for the first time as a child that are 2, 3, 4-shot series, and then we get a booster as an adult. So I don't think this is going to be anything different. It's just we tend not to get new vaccines for a new disease as adults, and so just working around this term of booster, making sure we get people protected. We need to get protected is an important thing. So Civil Beat published an article this morning. I was quoted, but I wanted to highlight a few important points, for this booster discussion. So definitely agree with Dr. Chang. For the immunocompromised, elderly, those with comorbidities, yes, that third dose is highly important to maintain a level of protection against not just infection, but hospitalization and severe death. But what the data is still showing is, across the healthy population, that, vaccines are still highly effective against what we want them to be effective against at the end of the day, which is hospitalization, severe infection, and death. And I was quoted as saying that, right now, the booster discussion in terms of boosters for all, that is in my sole professional opinion, that's a discussion that, that's a privileged discussion. If you look at majority of Africa, over 90% of Africa has yet to have even one dose, right? And the world is large, and the pandemic, we're still in a pandemic, and we need to get this under control across the world, but we tend to look at our own small bubble and just focus on that without without acknowledging that, with our transcontinental flights, we could be fine any given day in Hawaii because we did a good job, but because of inequities across the world, that could change in an instant. So we really have to shift a lot of our efforts to a global perspective. And with potentially what Dr. Fauci said about maybe potentially requiring a third dose for everybody, I think that's a decision that shouldn't be made lightly, because not only for the vaccine inequities globally, but there are some nuances with individual risk decisions based on individuals that may impact their future risk to COVID infection if they're already fully vaccinated with a 2-dose series. So once again, there's a lot of gray area. There's a lot of room for discussions with your provider. But at the end of the day, you should still get at least the 2 shots of the mRNA vaccine, Moderna, Pfizer, at the very least. And then transitioning on to at a higher level, at the WHO level, this is from a press conference from the Secretary General of the UN. And so I wanted to highlight a lot of key points that we may not be seeing in the national media. No country can simply vaccinate its way out of the pandemic. I hope that that's clear. Vaccines by themselves are not going to end COVID. You need to do a bunch of things: physical distancing, mask wearing, education. Looking at populations and demographics that are higher risk and targeting them, protecting our vulnerables. So I find it interesting and positive that the Secretary General of the WHO is saying it doesn't make sense to give boosters currently to healthy adults or to vaccinate children, or when health workers or older people, higher risk individuals are still waiting for their first dose, right? The exception is in immunocompromised individuals. So once again, this is a discussion of this booster discussion is one of privilege, and I acknowledge what Dr. Chang says, that the vaccines are already in Hawaii. It's not like we can take them and ship them to Africa. So yes, we should make use of them, but this is still a global issue that we are all part of, and we need to do our part, at least in education and getting the word out. So just wanted to highlight that. So let me see if that's the last slide. Let me see if there's any questions or any comments in the chat. Let's see. You have hundreds of questions. I mean, so do I. There's a lot we still don't know. I think we're closing on 2 years in to COVID being actually on everybody's radar. So we've been moving at warp speed. We've been learning a ton, but there's, you know, we definitely don't have all the answers, but we are moving, you know, at least scientifically, at a pace that is unprecedented in a good way. So, and any other questions? Aloha, Ethan. Hi, Marguerite. Thanks for joining. Long time no talk. It's, you know, semester's been crazy. You know, I'm still on active duty orders, so good to see you guys. So since you are like WHO, are you favoring their childhood masking policy? So, you know, I wouldn't say I'm like the WHO. I think, you know, I just highlighted WHO for this particular for this topic just because I concur with it. You know, what I am is I'm pro science, but I'm also pro, you know, looking at data as it evolves. And so, you know, what we do understand, you know, I think a larger discussion, the health community and, you know, other players in education space and mental health space need to relook constantly is, you know, it's a risk analysis of, you know, the current impact of COVID to our keiki versus, you know, balancing against long-term mental health education impacts that current COVID mitigation methods and measures are having on the development, both educationally and mental and socially, on our keiki. So, you know, definitely, I'm not a policymaker, you know, but I think looking at the data, there needs to be a re-evaluation based on new data that continues to come out across our state, the country, and internationally. So, you know, it's a hard discussion, you know, one that, you know, our elected officials need to relook, but that's why those are there, you know, they're in those positions of authority. But you know, from a scientific perspective, I think there is something that needs to be looked at. Yeah. So, you know, I think, you know, cloth masks are, you know, you'd be hard pressed to find that that's the gold standard, you know, before, you know, when there was a shortage in the beginning of the pandemic. That's all we had. So it's better than nothing, but supply chain has caught up. So, you know, the KN95s or surgical masks, it's much better. But I also think that, you know, you know, how much longer should we continue requiring mask wearing at schools? Well, what is the cost benefit, you know, what's the risk benefit to our keiki by requiring them, especially now that vaccinations are available for the 5 to 11? You know, there needs to be some balance, you know, with mask wearing, because, you know, I think there are some long-term impacts. Yeah, I think HiPAM could influence, but I think, you know, this is where we start to get much more speculative with our modeling. And, you know, there's so many factors, especially when it comes to the progression of disease and risk in the younger populations, because we don't have quite as much data. So it's harder to kind of calibrate our assumptions and our equations for a specific demographic where we don't quite have as much information. But no, I'll take a look at that meta-analysis. So thank you for sharing. Excuse me. Great questions. Yeah, I think, let me see if this is the paper. Is this a current peer reviewed? I have not. So I think there's a there, in terms of fading of boosters, right? What exactly does that mean? And let me see. I'm glad Marguerite is still here, to fact check me. I'm not a biologist or virologist, but my crude understanding is, if what we're measuring efficacy of boosters and vaccines, if we're looking solely at antibody levels, and that I don't think that's correct in terms of that's the gold standard of measuring efficacy, just purely because antibody levels will drop. That's they're not meant to stay at high levels your entirety of your life. That's why we have other mechanisms across our immune system to complement antibodies. You have memory B cells, you have killer T cells, right? So it's a bunch of factors that come into play. Yeah. So once again, boosters, it's not a one size fits all, and it's much more nuanced than we need to give boosters to everybody, or why are we giving boosters? And I think a large part of what is not being discussed a lot is the increased availability of cheaper early treatment options, to balance the discussion of prevention. Prevention is always key and is always should be the focus. However, understanding that we can't prevent ourselves out of COVID, because COVID will, none of our vaccines are 100% effective. So we need to work with what we have and what's being developed and create a very unified, as unified a strategy as possible, and communicate that to the public so that they're not, politics, and they're not getting involved, and they understand the science for what it is. So, I'm a big, HiPAM's a big advocate for just being transparent about what the data shows, what the science is, and what the limitations are. So, but great questions, RP. Thanks for asking this. Is there thoughts on HiPAM and lack of transparency for DOH? That's a question for HiPAM, writ large. I'm just one. I'm like one of the co-chairs. I don't represent all of HiPAM. We speak, we work together, but we also have individual thoughts and opinions. So unfortunately, I can't comment on that. But I can take that back to the group and see if we have any thoughts on that. I think we work with what we have. Let me see. Can you show the Marguerite? Let me see. Oh, I apologize. Let me see. Shucks. Sorry, Marguerite. RP was posing questions to just a panelist, but the previous question by RP was, are there thoughts on HiPAM on the lack of transparency from DOH, hospitalization, deaths, breakdown between vax and unvax? So I think, from my understanding, given how vaccinations are being tracked across the state, it's hard. Once again, I'm sure there's a way, but currently there's no neat way for DOH to tie into all of the various electronic health records across the various systems, the health record systems to track vaccination status. And also, when they take tests, whether it be at a drive-through testing facility at a hospital, I don't think DOH gets that patient information, that vaccination history. They just get the sample and then the test results. So could there be a methodology? I'm sure nothing's impossible, but I think to truly answer, once and for all, at least in Hawaii, efficacy of vaccines, and then the vax status for those who test positive in Hawaii. Yeah, it would be great to know from a research standpoint and just from a awareness standpoint. So, I think that would be nice to have, but once again, there are operational constraints that state entities are working with, and that I won't pretend to be to understand, just because I'm not part of that organization, and most of HiPAM is not. Well, the vaccines, the workers, they are powerful. They have, so yeah, so I would say for our models, once again, we no model can account for everything, and I think, we have to be strategic with kind our left and right limits, and there are a lot of things that impact the efficacy of vaccines, and it might not be the vaccines themselves, right? So I think vaccines do reduce future transmission and infection, but once again, there are other factors that influence that. So let's see, Gilbatraw has 100% population coverage for some booster level now. I can't comment on this country. I haven't even, is a city I haven't seen that before. So let me stop sharing and just kind of Google this really quickly. As an overseas territory. Let's see. Oh. RP, when can you switch to your can you share with everybody, just so Marguerite and the rest of the participants can see your country? So question is, there's a British territory, or it's a country in Europe that is the most vaccinated place in the world, but they're shutting down. I think they're Christmas is canceled. Oh, Gibraltar. Okay. Without knowing too much, once again, this is a my guess is I doubt the hospitalization. So I doubt the hospitalizations will spike. So once again, just because you see cases increase, cases are going to pop up even amongst the vaccinated population. Now, it could be something genetic. There are other factors, that we may not be aware of. Maybe there's a gene, maybe biologically that population is greater risk regardless of vaccination status. So, I think the thing with statistics is you can always find the exception to the rule and use that to poke holes in any type of argument. And so so if your point is vaccines may not work, may not reduce transmission, I would argue that the large amount of data worldwide goes against that. Now, once again, this is an exception, but epi statistics, we identify the exceptions, but we also look at the majority. And there is no such thing as 100% get something guaranteed in statistics or in epidemiology. The UCSF study showed vaccine and vax at same transmission level. So is it transmission level, or is it viral loads? Because people tend to mix up viral loads having the same viral load between vaccinated and unvaccinated, and equate that to transmission levels. So and without looking at the UCS study, I can't comment, but I think across the board you'll see in lay press and in social media, people you'll see people mixing that up. So once again, being very careful with what the data shows and then translating that to something that means something different. So once again, what we do know is that viral loads, yeah, they may be the same, But what the virologists are showing is that the amount of virus that is actually infectious in a fully vaccinated individual who gets COVID as a breakthrough case is much lower, even though the viral loads are the same. So once again, these are nuances that are not, as scientists, that we should be doing a better job communicating that. So, I think it's just, we need to do a better job across the board, scientific community, to really get at these nuances, and once again, boosters, it's really, I would, to RP, to your question, or to your point, how the booster uptake, once again, we do our best to look at the 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 data across populations and then make our best, estimates on the impact. But once again, that's why we have, in our models, we don't have just one, we have, upper and lower limits, just because there are so many factors, not just vaccines, but especially in Hawaii, we have travel, we have varying ethnicity levels, and so, that's the great thing about this. It's an every never-ending puzzle, but at the same time, we accept that there are many limitations, and we constantly try to address them. But it's almost, you will never find anybody who does modeling to say that we know it all, because it's just, especially in something as diverse as COVID, not just virus itself, but then you have the vaccines, you have social interaction, social uptake or lack of an uptake in the pandemic, and then some issues with data accuracy and translation. So we only work with the data that we have, and maybe that could be an inherent built-in confounder or bias, because we may not truly know what proportion of the new cases in Hawaii are vaccinated. So it's hard to calibrate when we don't have insights to some of the data that would make it easier for us to recalibrate, at least for the vaccine discussion. So, hopefully I didn't, I'm not trying to make excuses, but I want to be transparent with how difficult this is, even though, there are examples where, we could recalibrate it, but once again, we can't just rely on one study or one country that if we were looking at Gibraltar, right, how generalizable, right, and I talk about this in FE all the time, we can't just look at one country and it's an exception. If we're seeing across the board, across different populations, then it's generalizable, and then we can say, most likely it would be seen to occur in Hawaii, right? But the population, the demographics, the way it, the disease spread prior to vaccination efforts in Gibraltar completely may make that situation non-generalizable to Hawaii. So I'm not saying that what's happening in that country is not correct. It is, but we can't just take that one incident and then apply that to Hawaii, because that's not how epi works. That's not how modeling works. It needs to be repeatable across populations for us to truly use that for something as impactful as modeling for a whole state. So RP, great questions. Thanks for, that's what we have this for, is to be a forum to answer and to vet it. But yeah, no model is going to be perfect. It's just, especially given all of these inputs to it. So yeah, well, with that, thank you guys, Ethan, James, Marguerite, RP, for taking the time to have a good dialogue. We will see you next month, and then we'll have a one more time in December before the holidays, and then first one in the new year. So once again, stay safe, everybody. Make sure you maintain a positive, healthy lifestyle balance. Get outside, exercise, still protect yourself, but really get back outdoors. That's a safe space. So have a great rest of your afternoon, everybody, and we'll see you guys next month. Thank you. RP, I think Rukia published the link to the slide deck earlier in the chat, and you can find that on our HiPAM website.